Assalamu alaikum, good morning, good afternoon, and good evening, depending on your time zone. I hope everybody is doing great. Today, we are going to cover pediatric orthopedy, very commonly tested. Let me make a slideshow. Here we go. All right. So MCCQ1 pediatric orthopedics. Please remember that this is very commonly tested, very, very commonly tested. I cannot insist enough on this topic that you shouldn't be missing any pediatric orthopedics, especially this part that we are doing the lecture today. So the core exam task is to recognize age pattern diagnose. So please pay attention. You know, this when they're creating a scenario, one of the most important thing that they use at the beginning of each scenario is the age. So it means pay attention to the age, because by that you can tell this might be this specific condition, but not that specific condition. So it helps you to differentiate or distinguish between two or even three different conditions that they might present with a similar sign and symptom. Choose first investigation. What is the best initial investigation? Identify the urgent referral. What are the dangerous or red flags that when you notice, you should be referring it right away to the surgeon or escalate the management plan. Avoid harmful reassurance. We do not reassure without being 100% sure that it is not fatal or harmful for the patient. Please keep your mics off, everybody. Thank you very much. So 5 high-yield diagnoses that today we are going to focus on. It will be DDH, or developmental dysplasia of hip, which is in infants, slip capital femoral epiphysis, protesis in young children, and osgood in active teens, and nurse's mate elbow in toddlers. So these are the topics that today we are going to cover them. And based on these topics, we would be doing some cases afterward. So case-based thinking, the exam test best next step more than rare facts. So they're not going after rare facts. They're going after the best next step or the most common or effective or initial step. So in terms of diagnose, we have a few topics to discuss. So in terms of classic age, again, pay attention to the age. It will be newborn, infant. So usually you need to pay attention to the age and number of the age. For example, if it is anywhere between 4 to 6 or less than that, it helps you actually to know what would be my next step in terms of investigation. If it is above 6 months, obviously the investigation will change. If it happens beyond 6 months or beyond 9 months, then you know what to do next. Not only in terms of investigation, should you do escalation in terms of treatment or management, or you should just do the investigation and wait for the result to come back. So age is very, very important points of the scenario. You cannot miss out on that. So breach, when it comes to the developmental dysplasia of hip, usually I made a mnemonic. I will go one by one and cover every single one of them. And I made a mnemonic that helps you a lot to know everything about the hips and to recognize it and pinpoint it and diagnose it, and based on that, act on investigation and the treatment. So breach girl. So usually it happens if they give you a scenario about DDH, they usually give you an infant between age of 4 to 6 months, or maybe even younger, and it will be a female, and it will be first child. And maybe also they mention a family history of the same condition in the siblings. For example, he had a brother or a sister with the same condition. And also they may give you a clue about oligohydramnios that happened during the pregnancy. So these things should make you think that this might be the DDH or developmental dysplasia of hip. So I'm not going to confuse you a lot. So I'm going to pinpoint a few things, and then we are going to dive deep into every single topics. Okay. So something that they really need you or expect you to know is that you have to know it is going to be an infant. You have to know that mostly if they give you a scenario, it will be breech and a female infant. And again, they need you to know that what is the initial investigation based on age. So ultrasound and X-ray. So if it is younger than 6 months, do ultrasound. If it is older than 4 to 6 months, do X-ray. Okay. And if the infant is, let's say, older, 9 months and older than that, you can still do the X-ray, but refer. It is not your job. Just do the X-ray or order the X-ray and refer it to the specialist. Now, let's talk about the second one, which is the slip capital femoral epiphysis. Usually happens in adolescents. Usually, if they give you a scenario about this, they usually mention the BMI or the weight based on their height, and they're not directly mentioned that the patient is obese, but based on the BMI, you should be able to tell, oh, I have an adolescent and the BMI is over 25, for example. Okay. Or probably the patient is, let's say the height is this much, but the weight comparing to height is a lot. So indirectly, they will give you some numbers, and then you have to do the calculation and know that the patient is adolescent and obese, and he has a hip pain. Not only hip pain, the patient has hip and knee pain. The knee pain is radiation of the pain that comes from the hip, and the patient is limping. So no weight bearing and plus orthopedic. So this is emergency that you cannot delay it. You have to send it to surgeon. Pertes, usually same picture. Usually the same picture. But remember, age is different. Maybe the patient who comes to you also have hip pain and knee pain, exactly the same way that the SCFE or slip capital femoral epiphysis has it. But the age are different. Remember, in that and slip capital, it might be 13 years old, but in pertasis, it will be less than 8, somewhere between 4 to 8. 6 years old, 5 years old, 7 years old, 8 years old. Okay. And gradual limping, limited hip rotation, pelvic X-ray plus ortho. Both of them, you can do the X-ray if you want to, but they are emergency. You have to send it to specialist. Osgood. Osgood is Chalter, whatever you pronounce it. It is also happening in adolescents, but athlete, remember, tibia tubercle pain, anterior knee pain, like patellofemoral syndrome, and activity modification, same treatment, almost the same treatment. Nursemaid elbow usually happens between 1 to 4. So they might be 1 year old, 2, 3, or 4 year old. Pulled arm, pronation, and reduction if classic. So MCQ1, the child may present with a knee pain, but the diagnosis may be in the hip. So it means if they give you any child with a knee pain, it doesn't mean that you should forget about the hip and the ankle. So we check a joint above and a joint below. So if any pediatric population, any pediatric patient comes to us with a knee pain, it might be, the pathology might be within the joint and might be coming from the hip. In most cases, it might be from the hip. So it means you have to check a joint above and a joint below. Always examine the joint above and the joint below. Okay, now this is a very nice slide. I really like you guys to take a screenshot or just memorize it because it helps you a lot. So newborn, when you do a screening for the developmental dysplasia of the hip, it happens anywhere between 0 to 4 to 6 months. It can happen later on, but mostly it's going to be between this age. Now, the toddler nursemaid elbow could happen between 1 to 4, but most commonly, if they want to create a scenario, they usually love to put 2 years old. Okay, so anywhere between 1 to 4 is the right number, but usually they love to put 2. Like if I have seen 10 or 20 questions of nurse made elbow, like let's say 80% of them was 2 years old. So they love 2 years old. And young child protasia, usually, you know, it is between 4 to 8, right? 4 to 8 is the range of the age for this. But usually they put 6. So it doesn't mean they will not put, for example, 7, but they love to put 6. Again, 80% of the cases that have been made for this condition, 6 years old has been used. And now for the slip capital femoral epiphysis, 13 years old. And for the sport, anterior cruciating ligament and meniscus, usually they choose 16 if it is pediatric, okay? So infant hip screening, risk factor. What is the risk factor? Again, I will dive deep into it. I made a mnemonic, which is 6F. It makes it very, very easy for you guys to remember it. So breech, female sex, family history, exam, ortolani, and Barlow early. Limited abduction, we will talk about this as well. So a traumatic limb. So if you have a patient, if you have a scenario, if you get a case that you have a baby or you have a kid who is limping, but no history of trauma, think about one of these conditions. Now, based on their age, if it is young age, between 4 to 8, think about protease. If it is adolescent with obesity or overweight, think about slip capital femoral epiphysis. And if the patient is refusing to fever and refusal to walk, and passive range of motion is resisted or makes pain worse, think about septic arthritis. If the patient is also septic. In most cases, they might not have fever, but not in most cases, in some cases. So don't be fooled by the absence of fever. Arm, non-use. So toddler after traction, nurse's made elbow. Remember, for the nurse's made, we don't have to do X-ray for everyone unless there is swelling, bruising, and tenderness. Then if it is positive, then we do X-ray, then do the reduction, and then after reduction, we do another X-ray. But if it is not present, then just clinical diagnose, and you have to do just the reduction, okay? So exam rule, a traumatic knee pain in a child or adolescent must trigger a hip examination, okay? Now let's go dive deep into developmental dysplasia of hip recognition. So if they want to test you on this one, this is how the clinical vignettes will appear. They will give you someone with a breech, a female breech newborn, asymmetric thigh or gluteal folds. It is asymmetric. The gluteal folds will be asymmetrical. Limited hip abduction, positive ortolani or Barlow. I'm going to show you the picture to understand it better. So these two are a special test. If you are asked, probably these two might be one of the options as a special test that you need to do or a screening test. Leg length difference later. So if you do not catch it early stage, probably later on when the baby is crawling, you might see the leg length difference. Delayed walking and limp later. Now, the risk factor, just remember 6F. 6F. These 6F doesn't have to be all of them present in the scenario. Probably 2, 3, 4 of them might be in the scenario. So what is the first F? Feet first. It means breech. If they want to test you on developmental dysplasia of hip, usually they give you a scenario about the infant that who was breech. So breech presentation. Another F stands for female sex. It means if they want to test you, they give you an infant who is female. Not only she had a breech presentation, she's a female. And she was the first, she wasn't the first one. It means one of the siblings had the same issue. Family history is positive too. And now another thing, fluid low. I mean, oligohydramnios was positive during pregnancy. Not only that, the baby is the first baby sometimes. Usually, if it is the first baby, the family history would be positive in mom or dad. And fetal packing. Fetal packing is a rare congenital or genetic disease that the baby would have a dent in the skull. But that's not very common. But it is one of the F. Now, exam signs, ortolani reduced dislocated hip. Barlow provoked dislocation. Gigliazzi is apparent femoral shortening, which usually it is going to be the late sign. Limited abduction, again, later sign. High yield clue, limited hip abduction in an infant is never ignored. So they might not give it, because the baby might not give you very hard time. The only thing you may notice is when the baby is crawling, which in some cases they're not even crawling if it happens, which usually it happens at early age, right? So if you notice a hip abduction, that should raise an eyebrow that this is not normal. So you have to see a doctor. The earlier you take care of it, the better it is. Okay? So any hip abduction should raise an eyebrow. Okay, so normal hip, this is normal hip, and this is the developmental dysplasia. Shallow acetybulum, femoral head subluxate, displaced superiorly and laterally. That's why it is abducted, not adducted, abducted. So breech female, infant is classic exam clue. Usually they will mention this in the scenario. Limited hip abduction is an important finding. Positive ortolani or Barlow, which we are going to see this one. And this is the 6F, which we discussed it, right? So the best initial imaging, if the baby is less than 4 to 6 months, is ultrasound. If it is above that age, about 4 to 6 months, then do the X-ray, okay? Yeah, this is the Barlow. So remember, Barlow and ortolani, sometimes it might make you confused. So just remember B for bring close. B bring for close, and ortolani go away. B bring close or bring together. Remember it this way, bring close. So you bring it this way and extend, flex and push it outward. And this is very important for those of you who are doing the NAC OSCE. Probably they are not going to give you any standardized patient. Obviously, they're not going to give you, but at least you have to know how to do it, or probably they're going to be a mannequin or something that you can just do the maneuver, or at least you have to know how to do it properly. So in terms of investigation, very important slide, and they love to test you on this one. So they expect you to know this. and I have seen so many subscription with the cases that they want you to know what is the investigation based on the age. So newborn, less than 4 to 6 months, have ultrasound if abnormal exam or high risk follow-up. Early orthopedic referral, Pavlik harness commonly used. Early stage, you can use this one. Let's say if the baby is more than 4 to 6 months, then the pelvic X-ray becomes more useful as ossification appears. Orthopedic guided reduction, casting if needed. Late presentation, let's say the baby, you just notice that the baby is crawling and you see a discrepancy between two legs. So now you take the patient, your baby to the doctor, and the doctor says, oh, the baby has all late stage of the DDH. So in that case, prompt specialist referral, treatment more complex. Any age with a fever, toxic child, consider septic, arthritis until proven otherwise. So urgent inflammatory and infectious workup. Treatment goal, keep femoral head centered in the acetabulum to allow normal development. Pavlik harness maintains flexion and abduction, requires monitoring and follow-up. Complication, untreated. If you leave it untreated, what happens? Limb, pain, leg length difference, and early osteoarthritis. So osteoarthritis, we know this is not very common in pediatric population, but if you don't treat the DDH, that could be one of the reasons for osteoarthritis to appear very early in pediatric population. Okay, so out of all these complications, out of all of this, I made them all red. It means that you cannot forget about these complications. They love to test you on the complication as well. But out of all of them, the most commonly tested one is osteoarthritis, or the most common complication appeared in the exam or in subscription is osteoarthritis, that I need you guys to pay attention, not to forget about early osteoarthritis. Okay, so steam flow, how they give you the clue in this clinical venues. So they give you a breech, a female newborn just clank. When they do the screening, clank. They hear the clank. So what you should not do, reassure. This is supposed to be something to hurt the patient. So it means we don't have to do it. That's why I made it red. Don't do this. We do not reassure. So it means we have to evaluate based on the patient's age. Less than 4 to 6, ultrasound. More than 4 to 6, X-ray and referral. Okay? 6 weeks old with the abnormal hip screening. Do we have to do X-ray? 6 weeks is less than 4 months. I cannot do the X-ray. The best one will be ultrasound. I can do the pelvic. Remember, when they put 6 weeks, sometime since you're doing the exam, you're under a lot of stress. You are not only trying to get the question right, but you're also racing against time. So your eyes is moving really quick. So pay attention, take your time, read the words. When you see the 6, you probably your brain will say 6 months, move on, X-ray is the right one. But this is commonly mistaken. Even though you know it, you get the wrong one. Why? Because you don't read the week. That is 6 weeks, that's not 6 months. So read it properly, take your time, and the more question you do, the easier it will get, okay? So 6 weeks is ultrasound, not X-ray. 6 months, yes, then you can do the X-ray. Based on age, it is month, not week, okay? That's why I made it red, because very commonly mistaken by the IMGs in the exam. 3 months old, confirm DDH. So 3 months, less than 4 to 6 months. Confirm, do I have to give him antibiotics? So it has nothing to do with infection. It is just a dislocation. So what is the best treatment for this patient? is to reduction and hold it in the position for the proper development, which is called Pavlik harness. And if it doesn't work, if it fails, then surgery. Now, 9 months is late. It is 9 months. 9 months is late. It is above 6 months, right? So now what do? And I noticed the Galeazzi sign too. What is the Galeazzi sign? When you see the patient has one leg normal, the other one is shorter. It means discrepancy between the leg length. If it is positive, so it means the patient has the DDH. And if it is late, then I have to escalate the management. It means I have to involve the specialist. Urgent orthopedic referral. Fever, painful movement. We all know if you have joint pain, you have systemic symptoms, and you look toxic, this is septic arthritis until proven otherwise, regardless of the age. DDH exam language, clunk. Clunk is that sound, is meaningful. Click alone may be benign, but persistent abnormal exam still needs follow-up. So this is how the Pavlik harness supposed to be. I don't know how. So this is supposed to be, I don't know how to add the text right now because I'm in a slideshow. I don't think I'm able to do that. But anyway, so this is usually put and worn for 6 to 12 weeks. I don't know if I have mentioned it here somewhere. If I haven't, please write a note. So it's supposed to be worn for 6 to 12 weeks, and then it should be getting better. If it doesn't, then you need to escalate, okay? So what is Pavlik harness? Pavlik harness is a soft brace used to treat developmental dysplasia of the hip in the young infant. It holds the hip in the flexion and gentle abduction, helping the femoral head stay centered in the stipulum so that the hip can develop normally. Okay, so MCQ and key points. Best for the early DDH, an infant usually during the first few months of life. So it means if it happens at 9 months, then it's not going to work. So instead of doing this based on age, please pay attention. When we started this lecture, we said one of the most important points that we have to pay attention to any clinical vignette is the first thing that is mentioned at the beginning of the scenario, which is the age. So if it is 9 months, don't even bother using the Pavlik harness. Worn for the most of the day under pediatric supervision. Avoid excessive abduction, increased risk of avascular necrosis. Monitor response with a clinical examination and hip ultrasound. If the harness fails, then the hip cannot be reduced, closed, reduction, or spike or casting or surgery may be needed. So it means if it doesn't help, then you need to involve the specialist. So they might ask you, which they love to ask you, what is the first, best, or initial treatment or management for DDH who is 4 months old, which is going to be the Pavlik harness. So warning, do not force the hips into excessive abduction. Excessive abduction increases the risk of avascular necrosis of the femoral head, okay? Second most commonly tested, pediatric orthopedics. So slipped capital femoral epiphysis, classic vignettes or the clinical vignettes that they gave you, what do they include in that? They will mention adolescent. So usually around 13 years old, adolescent, often overweight. Remember, they might mention the child is overweight, or they may indirectly give you the BMI, which is above normal, or they give you, for example, he is 5 foot, but he is like 80 kg, something like that, that you can tell that, oh, the patient is overweight. So the patient is an adolescent, 13 years old, overweight, No trauma, atraumatic hip pain. So no trauma, hip, groin, and knee pain. In some cases, they also mentioned the thigh. But actually, the problem is the hip, right? The hip itself. But the pain that is in the thigh and in the knee is the referred pain that's coming or originating from the hip. So limb or externally rotated. The patient is limping and the leg is externally rotated. So the patient cannot do internal rotation. So they might mention the leg is externally rotated, or they may mention restricted internal rotation. Either way, you have to remember this. So maybe stable or unstable. Why it matters? Orthopedic surgery, because this is emergency, you have to do the surgery. Weight bearing can worsen the slip. So it means the first thing you need to do, ask the patient not to walk. So non-weight bearing, class orthopedic or specialist involvement. So unstable raise avascular necrosis. If it becomes unstable, chances of avascular necrosis is very high. Delayed diagnosis causes deformity and early osteoarthritis. The exam triggers adolescent knee pain, normal knee exam. The patient has knee pain, but no pathology is found. When you do the x-ray, you cannot find anything in the knee itself. So exam the hip. Always, if you have anyone with any joint, especially the knee problem, check one joint above, one joint below. All right. So workup and immediate management. So when should we suspect? And if we suspect, what should be our action and why should we take that action? For example, if we suspect somebody, and how do we suspect? Obviously, adolescent, 13 years old, overweight, hip, thigh, knee pain, no trauma. Okay, so the action we need to take, hip exam in adolescent, knee, thigh pain. Why do we have to do that? Because pain is often referred to knee. That's why we start with that. So protect immediate non-bearing weight. So in order to prevent from further damaging or further slip or making things worse, the first thing we need to do is immobilize the patient. We have to ask the patient not to bear weight on that affected side because it's making things even worse, right? Prevent further slippage. Image anterior, posterior, pelvis, and frog leg lateral if possible. Show the facial slip. Refer urgent orthopedic consultation, usually need surgical fixation. Usually they want to ask you this, what is the definitive treatment for this patient? Since this is a slip, right? I will show you in the picture so that you get it better. So this is a slip of so you have to do the screw fixation and stabilize the epiphysis. Stable the if the patient with a slip capital femoral epiphysis is stable, patient can bear weight with or without crutches. So this is what they call the stable, but still, even if they are stable, it doesn't mean they will be stable forever. Even for a stable, we ask them not to bear weight on the affected side. So unstable is they cannot bear weight and the chances of avascular necrosis very high. So features in terms of age, it will be adolescent, puberty age 13, but in Leclerc Perthes, it will be 4 to 8. In terms of body habitus, it will be often overweight or obese, endocrine risk of atypical, but usually for the Perthes, the age will be lower and the weight will be normal or smaller, and their younger age. Pain location, it will be in the hip, groin, thigh, or knee, hip, thigh, knee. So that's why it makes it a little bit hard for you guys to differentiate unless you know the age. unless you know the body habitus. Now, gait, almost the same thing. Gait is the same thing. Limb, external rotation, and internal rotation is limited. An exam, limited internal rotation, same thing. Again, immediate action for both of them, non-weight bearing plus urgent. For this one, you do the X-ray, then orthopedic referral. But if the X-ray is abnormal or you don't see anything, then you can do MRI, but you don't have to because it's emergency. You have to refer it to a specialist. So this is a picture of the slip capital femoral epiphysis, but the physiology femoral head remains in the acetabulum. This remains here, but this one slips through the proximal femoral phases growth plate. So the key point, the femoral head remains in the acetabulum while the epiphysis slipped posterior and inferiorly through the growth plate. This area slips. Like you can see it here in the X-ray. Okay, the clinical pairs, most common hip dislocation in adolescent, insidious onset limb and hip groin pain, may present with referred knee pain, which usually it will. Early diagnosis prevents further slip and complications. We did this. Early recognition, timely referral, prevent further slip and complication. And this is the single cannulated screw across the epiphysis in situ fixation. So they might ask you, this might be one of the question or one of the options in the scenario. So this will be your right answer. What is the definitive? If they ask you a question, they will ask you, like, they gave you a scenario about someone, let's say you have 13 years old, overweight, no trauma. The patient is complaining from the pain in the hip, groin, thigh, and knee. And the affected limb is rotated externally, and the rotation internally is restricted. So what is the definitive treatment for this patient? And the definitive treatment for this patient will be in situ fixation with a single cannulated screw. Okay, so this might be a question. So this is typical patient. We have already talked about this. Non-weight bearing for all of them. Do not force, so stable, unstable. If it is stable, then you do this. And if it is unstable, again, you have to stabilize the patient first, then you have to do the surgery. But still, you have to do either way. You have to do the surgery because that is the only way that the patient gets better, or you can fix it. Otherwise, a vascular necrosis chances are very high. Now, Lich-Calve-Perthes disease. Classic vignettes, or the clinical vignettes that they might give you. They might give you somebody who is between age of 4 to 8. For example, a boy age of 4 to 8, gradual painless or mildly painful limb, as opposed to slip capital femoral epiphysis, which is going to be very painful. This one is painless or mildly painful. So it's not going to be as painful as slip capital, but it is limping. The patient is limping. The age is younger, and the weight is lesser. Hip, and the pain is lesser. Hip, groin, thigh, knee pain, same thing. No fever, no toxic symptom or appearance. Limited abduction, internal rotation, same thing. The rest of the clinical picture is the same thing, like slip capital femoral epiphysis. Pathophysiology, it is an idiopathic vascular necrosis of femoral head. So fragmentation, this is something that they really need you to know. Fragmentation, reossification, and remodeling. This is the pathophysiology. Prognosis depends on the age and extent of the involvement. Prognosis per younger age and less femoral head involvement usually have better outcome. And this is very important. They might ask you that what is the better prognosis for this condition? Younger age, less femoral involvement. So if the age is younger, the femoral head is less involved, it will have better prognosis. Clinical task, suspect chronic limb. If somebody has somebody who is between age of 4 to 8, especially male, and the patient has a chronic limping, think about protease. So anterior posterior pelvis, frog leg lateral X-ray, MRI only if early X-ray is normal or inconclusive, but suspicious remain or still you're suspecting, then you have to do the MRI. But again, if that is really something that you're really seriously considering it, and X-ray is not showing anything, you ordered MRI and refer. Okay? A stable afebrile child, orthopedics referral, afebrile stable, but still limping, right? A specialist follows containment and femoral head shape. Treatment goals, preserve range of motion and containment, physio activity modification, bracing, surgery, and selected case. Differentiate infection. Obviously, anyone with a joint pain, swelling, fever, systematic sign and symptom, and toxic appearance, a septic arthritis, and we have to do the septic workup. So the MCQ on TRAPS, protesis not slip capital femoral epiphysis, younger child, insidious limb, avascular necrosis of femoral head. So for this one, it is idiopathic avascular necrosis of the femoral head and child. Age, usually, if they want to test you, again, pay attention to the age. It will be male, it will be 4 to 8, gradual limp and hip, groin referred pain, limited abduction, internal rotation, X-ray of femoral head will show flattening and fragmentation. X-ray will show flattening and fragmentation. Osgood. Osgood is, again, clinical vignettes. Usually they give you a scenario about someone who is adolescent, let's say around 13 years old, 12 years old, and he is an athlete. Anterior knee pain, like patellofemoral knee pain, patellofemoral syndrome. Worse with the running, jumping, same thing like patellofemoral syndrome. Stair, kneeling. Tender tibial tubercle. So anterior upper and anterior lower. Anterior lower is Osgood, anterior upper is for patellofemoral. Full knee range of motion, no effusion. Mechanism, traction apophysitis at the tibial tubercle, and patella tendon repeatedly pulse on a growth center. Symptoms fluctuate until skeletal maturity. Anatomy per patellar tendon insertion on tibia tubercle. So this will be in the exam. Maybe I should have made it red. So they might ask you about this anatomy pair. So remember this one, patellar tendon insertion on tibial tubercle. So something that helps you to differentiate between patellofemoral syndrome and also the Osgood, since both of them in adolescent, since both of them, patellofemoral can happen in the teenager as well, in the younger adult as well, but it can happen in adolescent as well, right? So one of the things that can help you is the location. Both of them happens at the anterior part of the knee, but the patellofemoral happens at the upper part of patella usually, but this one usually happens the lower part of the patella at the top of the tibia tubercle. Scenario, typical adolescent athletes, best management. So if it is athlete, typical adolescent, for the Osgood, activity modification exactly the same way you do the patellofemoral syndrome. Not in terms of counseling, if you're doing Nakoski, that you're educating the patient based on what he has, the condition and the management. It is not dangerous, reduce activity of limping or persistent pain. So basically you educate the patient about the condition, and then you have to do some modification and decrease the activity until the patient gets better, and you gradually increase it. So mild symptom during the sports continue as tolerated. If it is very mild, he can still go and play as tolerated. Pain should settle after rest. That is another clue. And painful flares, eyes, these are the things that you need to do in Nakoski. So the patient might ask you, okay, so what happens if the pain happens? What should I do at the flare? So for the flare, you have to use, for example, eyes, stretching, strengthening, analgesic, obviously if it is safe. Focus on quadriceps, hamstring flexibility, which we do it for patellofemoral syndrome as well. Atypical severe pain, if it is atypical but severe, which in this case, usually it is not severe. If it is severe, so it might be different. So we need to do investigation, consider X-ray. Exclude fracture, tumor, and infection. Persistent after maturity, a specialist review if symptomatic ossicle and rare needs surgery. Usually does not need surgery. It is conservative treatment unless it is complicated. But if it is persistent, despite being mature and receiving all the pharmacological and non-pharmacological treatment, then in that case, you have to involve the specialist as well. Osgood is extra articular, very commonly tested, no fever, no effusion, no true locking, very commonly tested. Nursemaid elbow, again, if they want to test you on this one, they will give you someone with a between age of 1 to 4. Usually, if you notice, I made 2 in a barricade. I put it in the barricade and I made it red. They love to use age 2. So commonly, if there are 10 stations about this, 8 of those stations is, or 8 of those cases are 2 years old. So pulled by the hand or wrist. Refuse to use the arm. The baby is refusing to use his arm. Elbow slightly flexed, not fully, slightly. And forearm is pronated, not supinated, pronated, and slightly flexed. No swelling or bruising. Mechanism radial head subluxation. So they gave you a scenario about this, and they may mention what is the mechanism of this injury. You have to know that this is a radial head subluxation, and this would be one of the options in multiple choice question. Go for this one, okay? If you see the red, it means that might be in the exam. Annular ligaments slip into the radiocapitellar joint. Pain resolved quickly after successful reduction. This is a mechanism. It's also supportive of the diagnosis. Like you have a condition which is clinically diagnosed, and when you do the reduction, the patient quickly gets better. So it supports your diagnosis, okay? If it doesn't help, or if the patient is not getting better, it means there is complication happen. Whatever happened, you have to do investigation. But for somebody who is clinically diagnosed, doesn't have any other red flags present, you don't have to do any imaging. But if the red flags, for example, bruising, bleeding, swelling, and all this is present, then you have to do the X-ray, do the reduction, do another X-ray to make sure everything is fine and move on. But in this case, if it is clinically diagnosed, you don't have to waste your time doing imaging. With one hyperpronation, the patient will get better and relieved. The pain will go away. Child looks comfortable unless arm moved. No focal bony tenderness. No deformity. Often starts using arm within minutes after reduction. So the patient has to get better right away within a few minutes. So the finding, classic traction injury, no swelling. So no red flag. Reduction with a routine imaging. So if you have no red flag, no dislocation, no bony tenderness, no swelling, no bruising, no bleeding, no cuts, so you don't have to do any imaging. Just do the reduction and that's it. Why? Because it's a clinical diagnosis. After reduction, use arm normally. Again, this is going to support your diagnosis and your reduction, parent education, that this is how it's going to be. And this is what happened, and this is how we fixed it. No cast or imaging is needed. Swelling, bruising, deformity is different. These are red flags. These are red flags. The patient has clinical picture of nursemaid elbow, but on top of that, the red flags are positive. I mean, swelling, bruising, deformity, bleeding, bony tenderness, all this. You can see that the patient has that on top of the clinical diagnosis. Then I have to do the x-ray first and then do the reduction based on the imaging finding. Exclude the fracture. So point tenderness or fall mechanism. If there's a point tenderness and a fall, there is a trauma of fall. Like when you're moving the baby, holding the hands, it's also trauma. But if there is a fall trauma and pointed tenderness, again, I have to do the x-ray. No classic, not classic, nursemaid. Classic nursemaid has no trauma. I mean, it has trauma by pulling, but not trauma by hitting or crashing to something or falling. Still not using arm after reduction. So let's say you already diagnosed it clinically and you did the reduction and the patient is not improving. I mean, the symptoms are not improving. The patient still have the pain and the patient is not using the arm. So fail reduction or fracture. Now, in that case, you can escalate. So parent advice, avoid pulling. So if you're doing a Nakoski, what should be your education on counseling? So what is this condition? What is the mechanism that it happens? What are the complications that it can cause? What do we do now? And what should you do to prevent it from further or happening again? And at what condition you should bring back the baby to the hospital or to the nearest emergency room. Those are the things that you need to know and cover for the consultation if you're doing the Nakoski. Sorry. So this is about the nursemaid elbow, pronated, slightly flexed. So this is a step-by-step reduction. Support the elbow, hold the forearm near the wrist, and hyperpronate the forearm, and the baby will say thank you, and everything gets back to normal. So subluxation of the radial. I have seen this ligament once in one subscription. I'm not sure that they might test it, or it might be very commonly tested, but it doesn't hurt if you just cover this one as well. So annular ligament slipped over the radial head, this subluxation, and this is why it happens. It doesn't hurt if you.
Sorry, I'm still discussing the.
I would appreciate if you guys keep your mic off. Thank you. All right, so limp, the limping child. Now, let's talk about if we have a child who is limping. So fever toxic, it is septic arthritis until proven otherwise. Any joint pain, fever, toxic, refuses to bear weight, severe passive range of motion is septic arthritis until proven otherwise. If my patient is anywhere between 4 to 8 and the patient is having gradual limp or chronic limp, limited hip abduction, internal rotation, it is pertussis, I have to do x-ray, plus I have to involve the specialist. Why? Because this requires an urgent care by a specialist. This is not something that we can deal as a family physician. Remember, when you're doing an exam, And MCCQ1 or NACOSCI, you have to know that everything that you do it from a perspective of a family physician, not a surgeon, not a specialist. Even if you are a surgeon or a specialist, just deal with it like a family physician, like a GP. This is what they expect you to approach the case, not as a specialist, not as an, for example, medical student. You're neither a medical student, you're not a physician specialist, you're a family doctor or a GP. Everything you do it within this chart, a GP. Okay. Once you pass the exam, then obviously you're going to be a specialist. Then your perspective will change. But for now, for the MCQ1 and NACOSCI, you're neither a medical student nor a specialist. You're a GP, and they expect you to approach every station and every case as a GP. I hope it makes sense. Okay, so adolescents, I have an adolescent patient. My patient is obese. He has knee pain, limited hip internal rotation. It is slip capital femoral epiphysis until proven otherwise. So non-weight bearing for me, for my patient, and urgent orthopedic. Anterior knee pain, tibia tubercle tenderness in athletes. This is Osgood, not patellofemoral syndrome. Patellofemoral syndrome, the patient will have anterior pain, but it will be above the patella. So conservative treatment for both cases. Pain after trauma, deformity, swelling, inability to bear. Obviously, it might be a fracture or a vascular or neurovascular damage. So I have to do the imaging and I have to involve specialists. Do not diagnose growing pain when limb, focal tenderness, fever, or loss of hip range of motion is present. Obviously, if you have fever, you have swelling knee, you're not going to think about anything else until you rule out the septic arthritis. Referred knee pain, the hip is often the answer. Okay. When knee exam is normal, atraumatic knee pain, limb, hip rotation limited, pain in thigh and groin, foot progression outward, it is hip, it is not knee. Think hip diagnosis, slip capital femoral epiphysis in adolescent, preteris in the young children. So this one is 13 years old, this one is 4 to 8 years old. Septic arthritis, any age, regardless of age. Febrile, toxic, swelling, systemic sign and symptom, monoarthritis, aseptic arthritis until proven otherwise. Transient synovitis, if benign viral patterns, exam move, assess hip, internal rotation, abduction, gait, and ability to bear weight. Compare both sides. Always. So for those of you who are doing the NACOSCI, when you do or perform a physical examination on one side, you need to compare it with the other side. For example, if you're performing an anterior drawer test for anterior cruciating ligament on the left knee, once you're done, then would say, I would compare it with the other side. And 99% of the time, the examiner will tell skip, or he will tell you that's normal, go ahead, move on to the affected side. And if you want to do the Latchman, again, I would like to prefer it to the other side. But you have to verbalize it, okay? High yield exam traps, adolescent with a knee pain and obesity. It is slip capital femoral epiphysis until proven otherwise. Very commonly tested. Please remember adolescent, knee pain, obesity. Adolescent, knee, hip, thigh pain, obesity is slip capital femoral epiphysis until proven otherwise. High yield pediatric orthopedic science and test. Ortolani for DDH. Reduction of dislocation hip, palpable clunk. Barlow, DDH, provoke dislocation and unstable hip. Galeazzi sign is the late DDH or developmental dysplasia of hip when two legs length are different, or the affected area is shorter, apparent femoral shortening, uneven knees. So limit hips internal rotation. It could happen in slipped capital femoral epiphysis and pertasis, both of them. This is 13 years old. This is 4 to 8 years old. Hip pathology, knee pain may be referred. Tibia tubercle tenderness is osgood. Traction apophysitis at the patellar tendon insertion. This is what they need you to know. Patellar tendon insertion. Traction plus pronated arm, nursemaid elbow. This is what they expect you to know, and this might be one of the option in the question. So radial head subluxation. Now for the imaging choice, what MCQ1 actually expects. So for DDH, if it is younger, let's say between 4 to 6, what do? Ultrasound. Do not forget the cartilaginous femoral head. If the patient or the baby is above 6 months, then we do X-ray. So older infant, anything above 6 months, we do the X-ray, and then we involve the specialist. Slip capital femoral epiphysis, we do the anterior, posterior, pelvic, and frog leg lateral if the patient is stable, or if the patient can bear weight, or if the patient can actually do that. Otherwise, anterior, posterior would be more than enough. Non-weight bearing before imaging logistics. So pertasis, anterior, posterior, same thing. MRI, we do X-ray, but if X-ray is inconclusive, then we do MRI. But again, MRI and referral. Nursemaid elbow classic. No routine imaging. We never do imaging unless we have the red flags present. What are those red flags? Swelling, bruising, tenderness, fall, failed reduction. So in these cases, we can do the imaging. Otherwise, it's clinical diagnosis. We don't have to do any imaging for the nursemaid elbow. Osgood, usually clinical. X-ray if atypical or severe. So for Osgood, it is very clinical picture of someone who is, let's say, adolescent, athlete, anterior knee pain, the tibia tubercle tenderness, and the patient is not having any symptomatic or toxic appearance, and the patient has pain, but it's mild. You can do some modification in the exercise, and the patient still can bear the exercise while he is doing the modification, and he can still continue the exercise with a mild pain. But if it is getting severe and the patient gets symptomatic symptoms, fever, and he starts to get, for example, severely limped, then in that case, I have to do X-ray in order to rule out the complication, for example, the infection, inflammation, fracture, and so on and so forth. Urgent referral and emergency triggers. Immediate emergency, febrile child refusing to bear weight. You have a child, toxic, does not want to walk. So it is septic arthritis until proven otherwise. So you need to immediately refer it to hospital and a specialist. Severe pain with a passive range of motion. Again, this is also septic arthritis. One of the characteristic finding of septic arthritis is joint swelling, red, painful. What is systemic symptoms like fever and so on? And the passive range of motion is painful, or it makes it worse, or it is restricted. So toxic appearance, obviously, neurovascular compromise, open fracture or deformity. These are all emergency. You have to send the patient to emergency room. Urgent orthopedics, suspect slip capital femoral epiphysis, orthopedics. Late DDH, orthopedics. Pertasis, orthopedics. Failed nurse made reduction. You did the reduction, but the patient is not feeling better. So the patient within a few minutes, I mean, the baby has to start smiling, the pain should go away, and the patient should start moving his or her hand. If not, then orthopedics. Locked joint or major limbs, obviously. Conservative, usually OSCOT. Classic nurse made after reduction. It happened while they were playing, so you did the reduction, the patient is getting better, so you don't have to escalate it. Patellofemoral pain, obviously, it doesn't need any escalation because this is just repetitive damage, and it is getting better by the modification. Physiotherapy is strengthening of the thigh and the calf, and we don't have to escalate it. Mild overdose injury, overuse injury. So just rest, modification, and strengthen of the big muscles like thigh. For MCQ1, red flags change the answer from reassurance to image, aspirate, non-weight bearing, or refer. So always, if anyone comes with any pain, this is something that you need to look for. In the scenario, does my patient have, on top of this, the patient has pain, but does he have any red flag with it? If red flags is there, then your answer from reassurance or conservative treatment moves to emergency or urgent care or referral to specialist. So pay attention to the red flags. So it's very important whether you're doing MCQ1 or whether you're doing the NACOSCI. So if you're doing MCQ1, they give you a scenario, then they give you the chief complaint, and then at the middle, they will throw some red flag. But if you're doing NACOSCI, when you're taking history, you need to ask for it. So for example, if the patient says, I have a pain in my knee, so you need to ask, is there anything else along with the pain? Have you noticed any changes? For example, any swelling? So these are the things that you want from the patient, right? You shouldn't directly say any swelling, any redness, and this and that. No. Any other changes that you have noticed recently? Then the patient has to tell you, yes, swelling. I can't move it. When somebody moves it, it gets worse. Not only that, I have fever. And I'm feeling very fatigued. And I'm nauseated. So these are the things that makes you think that my patient needs an urgent care. Why? Because if you have a proper history, you would be in a better position to do a healthy and a very useful consultation. If you don't have a proper history, whatever you say in the consultation might be irrelevant. Common MCQ1 pitfall, how to avoid wrong answers. So, wrong assumption, knee pain means knee disease. It's not always like that, especially in pediatric population. If the patient has knee pain and when you can't find any pathology within the knee, it doesn't mean the patient is just thinking that he is sick, but he is not. So go above one joint above and go one joint below. Usually for the knee, the joint above would be affected. For example, in terms of pertase, in terms of slip capital femoral epiphysis. So these are the traps. They give you a scenario about someone, for example, let's say you have Ahmad, 7 years old, he has a knee pain and he has been limping for, let's say, 2 months, and the x-ray of the knee came back normal. What is the best next step? The best next step is to reassure the patient, to just give him a Tylenol, just tell him not to work out. Or the other one is to investigate a joint above and joint below. And the last one, none of the above. So obviously, out of all these options, check the joint above and joint below. So mostly the pain might be a referred pain coming from the hip. So if you check the hip, you might notice that the patient has a slipped capital femoral epiphysis. and you take care of that, the pain that is referred to the knee will disappear. Exam hip in children with adolescent. Normal newborn exam exclude DDH. So normal newborn exam exclude the DDH. Sometimes it might looks normal, but it doesn't mean it's going to be normal forever. So it means every visit we have to check. Risk factor still matters. Follow high risk breach and fans. Slip capitofemoral epiphyse can walk, so not urgent. So remember, in slip capitofemoral epiphyse, we have two conditions. Either the patient is stable or unstable. What is stable? Stable if the patient has this condition, but he still can walk. He has a limp, but he still can walk or bear weight on the affected side. Unstable is that the patient has the slip, has happened, but the patient cannot bear weight on the affected side. So either way, this is a surgery related condition. So the patient has to get a surgery done. Either way, we have to advise or consult the patient not to bear weight. Okay? Nursemaid elbow, always no x-ray. We normally don't do the x-ray, but it doesn't mean always we don't do it or we never do it. So for the nursemaid elbow, it's a clinical diagnosis. You take a history. Based on the history, the patient, for example, I was playing with my kid and I was just holding his hand from the forearm and I was just trying to play around with him. And then suddenly I heard a pop and then my baby start to flex his hand and hold it like this, and he is crying and he's not moving it. So you know this is clinical picture of a nursemaid elbow. You do the hyperpronation and the patient gets better, and you don't have to do any imaging. But it doesn't mean that you never do the x-ray. If there is a bruising, if there is swelling, if there is dislocation, if there is a point tenderness, if the patient says I was playing, but suddenly I lost the balance, or he hit the ground and then this happens, so it's a trauma. It is a trauma that happens due to a crush, due to a fall. Now, in that case, I have to do an x-ray to make sure that there's no fracture. Then I do the reduction, and then I do another, if for example, the patient is not getting better or the reduction is not helping, then I do another x-ray just to make sure that find the right reason for it. So nursemaid, always no x-ray is wrong. Only if classic. We don't do the x-ray only if it is a classic clear-cut picture of nursemaid elbow. But in complicated, with a risk factor positive, we have to image when swelling, bruising, tenderness, and dislocation or deformity. Dislocation is obviously there, fracture and bleeding. In that case, you have to do it. Osgood knee surgery, no. Usually self-limited, and activity modification and stretching and strengthening of the thigh and calf will help, and it will disappear. So differential or differentiating the 5 diagnoses in one table. Okay. DDH, infant, pain location, usually it is painless, so you won't notice it. The baby is not going to give you a very hard time or cry a lot about it. But that's why it's important to have a regular visit to your family doctor, because they have to do the Barlow and Ortolani, because by the time the baby is started to crawl, it will be too late. So you have to take the baby in a regular visit so that the screening happens, because they have the special screening test, the Barlow and Ortolani. Limited abduction, Ortolani and Barlow, and also the Gileasi will be the late sign. Ultrasound if the age is less than 4 to 6 months, and X-ray if the age is more than 6 months, plus orthopedics. Slip capitofemoral epiphysis, adolescent, 13 years old, hip, groin, thigh, knee pain, limited internal rotation, external rotation gait. The patient gait will be externally, the affected limb will be externally rotated, and the gait will be like that. and non-weight bearing plus argent ortho. Pertase, ages 4 to 8, usually male, but that can happen to anyone. Hip, thigh, knee, gradual limbs, limited abduction, internal rotation. The rest of the picture is the same thing. Exception is the pain that is much lesser comparing to slip capital, and the age. The age is less, the pain is less. Pelvic X-ray, if it is negative or inconclusive, then do MRI and then do the orthopedics. Osgood adolescent, again around 13 to 16 years old, anterior knee, tibio-tubercle tenderness, activity modification, nursemaid is usually between 1 to 4. Usually the very commonly tested age is 2 years old. Arm, elbow, non-use, pulled arm, pronated forearm, no swelling, no tenderness, no bruising, no fracture reduction if classic. If it is not classic, then you have to do the imaging, then do the reduction if it is required. And obviously based on the imaging, you have to decide. So you have a breech female, newborn with a limited hip abduction and climb. What is it? DDH, developmental dysplasia of hip. So what do? I can do either ultrasound or I can do X-ray. Now, based on my age, I have to decide. Less than 4 to 6 months, ultrasound. More than 6 months, X-ray and orthopedics. Now you have 6 weeks. Remember, it is week, not months. 6 weeks old, breech infant with abnormal screening. So I have 6 weeks. Do I have to do X-ray? No. Hip. Why? Because it is less than 4 to 6 months. So it is 6 weeks old. 9 months, now this is too late. It is above 6 months. Galeazzi sign, it is late sign. It means when my baby is crawling, I can see the difference or discrepancy between 2 knee and 2 legs. One is shorter. So when I notice that, it is too late. It is a late sign. So that's called Galeazzi sign. And limited abduction. So for that, what do I do? Do I have to do ultrasound? No. First of all, it is 9 months, more than 6 months. I have to do an X-ray. Secondly, I have to do refer it to orthopedics. This is not something that I can take care of. 4, 13 years old with obesity. I have adolescent, obese, knee pain, limb, limited hip, and also internal rotation. Internal rotation is restricted and the patient has hip, thigh, knee pain, adolescent, obese. It is slip capital femoral epiphysis until proven otherwise. What do? I can do X-ray, but it is emergency. If you have an option for X-ray, you can do, but you have to refer it to orthopedics. Suspect, but the child can still walk. So you have this patient, but the patient says, you know what? It hurts, but I can still walk on it. Do you want me to do that? Continue doing that? No. Still no weight bearing because it makes the slippage worse. Now you have another case, 6 years old with a gradual painless limb and limited hip range of motion. First of all, what is the age? The age is 6. So 6 to 8, 4 to 8, 6 is right in the middle. So 6, probably if my patient has a limb, it might be pertase. So another thing that makes me think about it is the patient has limb and it's gradual, it is chronic, and it's painless. Remember, we said the difference between pertase and slip capital is that the pain is less and the age is less. 4 to 8 for the pertase, and for the slip capital, it is 13. Unlimited range of motion. Almost the rest of the clinical picture is the same thing. So it is pertase. Child with pertase, first imaging choice is X-ray. And then you can do MRI if X-ray is not helpful or conclusive, and you can refer it to the orthopedics. Pertase mechanism. What is the mechanism? It is a femoral head, a vascular necrosis, and it's idiopathic. Nobody knows why, but it is a vascular necrosis of the femoral head. 13 years old, athlete with tibial tubercle pain, I have an athlete, 13 years old, and the patient has pain in the anterior part of the tibia and tibia tubercle pain and tenderness, and the patient is athlete, so oscut. If it is above the patella, I would think more about patellofemoral syndrome. Oscut with a mild sport pain resolving with the rest, continue as tolerated. Toddler pulled by hand, arm pronated, no swelling. What should I do? Do I have to do X-ray? No. It's a classic nursemaid elbow. So this radial subluxation. For this one, I have to do the hyperpronation, which is the reduction. That's it. No imaging is needed. So if you have classic nursemaid elbow with no red flags, reduction maneuver, no imaging. Pulled arm with a swelling, bruising after fall. Now this is different. It's not classic nursemaid. It is the radial subluxation like condition secondary to trauma or fall trauma. Now I have to do the X-ray to rule out fracture. Use arms normally after reduction, parent education. No arm use 30 minutes after reduction. This is worrisome. This is something that you have to reconsider or escalate the investigation and reassess. DDH, breech female, infant, limited abduction, evaluate early, ultrasound in younger, and X-ray for the older than 6 months. Slip capital femoral epiphysis, adolescent with obesity, hip pain, knee pain, non-weight bearing, urgent orthopedics. Pertase 4 to 8, gradual limb, chronic limb, painless, mild pain, pelvic X-ray, and if it is inconclusive, MRI and a specialist. Oscut, adolescent athlete between 30 to 16 years old, usually 13, with a tibia tubercle pain, anterior knee pain, tibia tubercle tenderness, conservative, active, guided care. No surgery. Nursemaid elbow, if it is classic, reduction. Imaging if the red flags like bruising, swelling, tenderness present, or the reduction doesn't help. After 30 minutes, the patient is not improving. Universal rule, fever, toxic appearance, refusal to bear weight, and severe passive range of motion is septic arthritis until proven otherwise. So MCQ1 rewards safe next step, protect the limb, image appropriately, refer urgently when needed, and avoid unnecessary procedures. This is the whole thing that we discussed in one slide. Developmental dysplasia of the head, usually an infant, right? Up to 6 months. After 6 months, we do X-ray. Before 6 months, we do ultrasound. And what is the best treatment for for an infant who is less than 6 months? A Pavlik harness. After that, we have to involve the specialist. Most probably, close reduction, spica, or surgery. For slip capital femoral epiphysis, usually the patient will have external rotation. If you notice, obese, adolescent, internal rotation is restricted, the gait is externally rotated, the patient has hip pain, thigh pain, knee pain. And the patient will, this is emergency. So for the leg, if you notice, slimmer, younger, 4 to 8, not adolescent, 4 to 8, same thing, pain in the hip, thigh, and knee. But the pain will be much lesser. The pain will be much lesser compared to the slip capital femoral epiphysis. And also, this will be gradual limb, but both of them are emergency. I mean, referral, and they both need surgery. They may ask you about the prognosis for this one. The younger the age, the less the femoral head is involved, the better the prognosis. Okay. Osgood, again, 13 years old, same age, but this one is hip, this one is knee. Not only knee, tibia tubercle. So remember, in patellofemoral pain, you also have anterior knee pain. Anterior knee pain right here, where he is pressing, and in femoral, patellofemoral test, usually it is on the patella and above the patella, not lower or tibia tubercle. Okay, and thank you very much. End of pediatric orthopedics.